is it bad people or is it bad systems,
Yeah.
right, that cause errors, right? And I think bad people is a pretty small minority of the harm that occurs in healthcare. It's generally bad systems, right? We haven't designed systems in ways that let healthcare workers deliver the best care all the time in every situation.
AdvoKAYte, holding healthcare accountable. This podcast is my way of sharing what I've learned about the mistakes, the cover-ups, and the ways we can all protect ourselves. We're all in this together. Hello, everyone, and welcome back to another episode of AdvoKAYte, holding healthcare accountable. I'm super excited to have as my guest today Dr. Matt Austin. Dr. Austin is a PhD in patient safety. So I'm super excited to get into this conversation with him. And I'm also super honored that he would agree to come spend his time talking with us today. You're going to find this extremely fascinating. And let me just give you a little teaser into what this episode is about. For decades, we've always thought of medical error as human failure. People think, my doctor screwed up. Well, that nurse wasn't on the ball. That nurse screwed up. But the science of patient safety has taught us, and studies have revealed, that most human error can be engineered out with proper systems. But the healthcare system itself is a broken system, which instead of leading clinicians to the non-mistake route, often because of the way the systems are designed, pushes clinicians into making these mistakes. And therefore, in fact, the systems that are engineered inappropriately are indeed the root cause of so many preventable medical errors. We're super excited to welcome Dr. Matt Austin, and stay tuned. We're going to jump right into it. Welcome, Dr. Matt Austin. I'm so thrilled that you've agreed to join us for 2 episodes of this podcast.
Well, Kay, thank you so much for inviting me. It's a pleasure to be here and look forward to chatting with you today about patient safety and this important issue.
Well, I really do mean what I say, that I'm really honored that you would take your time to join me and to talk about these very important issues. So let's just jump right into it if you're ready.
Perfect.
Okay. Well, Dr. Matt, first of all, whenever I try to describe what it is that you actually do, I'm probably going to mess it up. So will you explain to the listeners what you do in your professional life as a PhD level patient safety expert?
Yeah, happy to do that, Kay. So thanks so much. So I come from an industrial and systems engineering background. And just a little background about me is I actually, out of college, worked in the airline industry for about a dozen years prior to coming to healthcare. So I worked for both American Airlines, which is based there in the Dallas-Fort Worth area, as well as what was Continental Airlines, based in Houston, Texas. So I'm a Texan for about a dozen years, and then moved over to healthcare. And what industrial and systems engineers focus on is how do we think about systems, specifically the integration of people, machines, and materials to make processes and systems work better. So in the airline industry, I was really focused on airports and how do we make the systems of the airports work better. And in healthcare, I've really been focused on how do we improve the quality and safety of healthcare delivery, primarily in hospitals, but in other healthcare settings as well.
Well, you know, it's interesting because if I understand correctly, a lot of the science of patient safety is drawn from the airline industry.
Yeah, so we think of the airline industry, we think of nuclear, the nuclear industry as being sort of high stakes, low opportunities for mistakes to be made. And those industries have really, I think, taught us a lot in healthcare about how we need to think about errors, How do we need to prevent errors? How do we need to investigate errors? Because in the United States, we have over 4,000 hospitals that operate in all 50 states, and so we have a challenge in healthcare of sort of um, spread that we don't quite have in maybe some of those other industries. And so it's been a little bit of a challenge at times to apply those principles to healthcare, but I think they definitely teach us a lot and sort of give us a roadmap for what we should be doing.
Well, it is so fascinating to me because, and I don't want to get ahead of myself, but it's what I tend to do. The flying on a commercial airplane is actually relatively safe because of the systems that they have, and very, very few people die as a result of a pilot error. Is that fair?
Yeah, I think that's a fair statement. And I think those in aviation would say, it continues to get safer year to year, right? That we continue to make improvements. And a lot of that is, the use of checklists, it's redundancies, right? You have actually two pilots that are in the cockpit who are there to sort of check and double check with each other. And so I think that there are some, safety mechanisms that they've put in place to really help that. And I think you're right. It continues to be an incredible safe of transport and perhaps gets even safer year to year.
Compare and contrast to a patient going into a hospital.
Right. Where that's great question, right? So the statistics are a little varied depending on the source you look at. On the low end, we're probably talking about 100,000 patients that die in hospitals each year due to preventable medical mistakes. Some of those estimates from like John James and others have been as high as 440,000. It sort of depends on what you include and what you don't include, but the magnitude of harm is high, and is obviously a lot more than what we experience in aviation. The 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 analogy that gets made a lot is, we have the equivalent of three 747s crashing every day as a result of patient harm in the U.S. healthcare system. And what people would say is if that was happening in our aviation system, we would be doing a whole lot to understand what was happening, why that was happening, and what we would do differently. I think what's different about healthcare, as I mentioned, is those events are happening across 4,000 plus hospitals, and they're very spread out, and they're happening in different units and in different ways. And so that often sort of gets lost, right? Each of those events is seen as sort of a single event, but yet if you sort of aggregate everything together, we're talking about big numbers of patients that experience harm.
Well, it's a sobering statistic to say the least, but you know, I'm a girl from southwestern Oklahoma, and I tend to kind of break things down into really practical terms. And I think of it this way: if three 747s were going down every day in the United States and killing everyone on board, the number one thing is there would be public outrage. People would be marching on the Capitol saying, do something about this, and something would be done about it. But number two, people would refuse to fly. They would drive. They would take the bus or the train, or they wouldn't go at all. But people do not have a choice about whether to be a patient. And so, we could talk for hours about this, but I have my own opinions, but I'm interested in what you think the reason is why healthcare hasn't been held accountable for their abysmal safety record and what it's going to take for them to get serious about it.
Okay, I would love to hear what your thoughts and opinion is on this as well. So maybe after I give mine, you can give yours, and
Okay.
yeah, it will be helpful to. I would challenge you a little bit on the term abysmal. I think there are too many patients that are suffering harm from medical errors in hospitals. Yes. Do I think there are folks that are working tirelessly day in and day out to make that better? Yes. And I think we need to hold that up. We need to sort of recognize that improvement is something that I think everyone is motivated by. I think getting there is hard. It's hard to sustain and it's hard work. I think some of the challenges are that, as I mentioned, that, if I have a fall in a hospital as a patient and injure myself, who does that get reported to? Meanwhile, across the country in New Mexico, there's a patient that has a medication error. On the same day, there's a patient in North Dakota that develops a pressure ulcer from laying in bed too long, right? So all these events are happening, but they're different types of events and they're spread, right? The 747 going down is everyone's together. It's sort of a mass casualty at the same time. And so I think some of it is how do we bring more attention to the data? I think it's also been really hard to find who are the advocates for really, challenging the current systems and saying we want better, we deserve better, and that there's competing interests. I think also within the healthcare system, there's financial, constraints and challenges. I think generally we have a workforce that's being overworked, right? There's a lot of healthcare worker burnout at the moment. We're asking them to do more and more and more. So I'm not in any way trying to make excuses. I think the level of harm is too high. I think we need to do something about it. And I think it's challenging for us to do that.
Well, I think that's very fair assessment. And part of what I love about this podcast is getting to talk to people and being willing to disagree. That's something that we've lost recently in society, is that people can respect the heck out of each other and come from a little bit different viewpoints and have a spirited debate. So, this is what I would say. And believe me when I say I have spent my entire adult life trying to get to the answer to these questions. And I think it is because not every institution is similarly motivated. You are with an internationally famous institution, Johns Hopkins. You are affiliated with the Armstrong Institute, which is internationally famous. You're at the forefront of patient safety. But in my practice, when I'm at the other end of it and I'm seeing the catastrophes, the people and families that are devastated by these preventable medical errors, what I see is the hospitals and corporations that are not so motivated because they have other pressures, such as producing profits for the corporation, producing profits for the hedge fund that owns the entity or whatnot. I also see that there are external pressures, such as insurance reimbursement rates, that are contributing to healthcare workers being overworked. I see corporate ownership coming into hospitals and intentionally understaffing so that they can squeeze out, there's some pencil pusher in the C-suite that says, if we could understaff these units and make these nurses work harder, then we can boost the profits. And lastly, it brings me full circle to why I'm doing this podcast. Because about a decade ago, when I started seeking out patient safety advocates and to say, can I join you and can I start trying to be part of the solution, what I learned is that it is a very fragmented, not well-funded group of really good people. And so if you look at it comparatively to the number of people that are dying unnecessarily in the United States every year, and you might compare that to cancer or heart disease, patients don't have an American Cancer Society or a American Heart Association. Heck, We don't even have a Susan G. Komen Foundation. And if patients need anything, they need some enormous benefactors like a Susan G. Komen or someone to fund this. So, anyway,
No, and I don't disagree with you at all, Kay, about the financial pressures, right? And perhaps putting patient safety further down the priority list and putting profits, as I like to say, putting profits over patients, right? So I think that is a real thing. I just in conversations that I have, I often hear a desire to make things better, right? So that's not to say that's universal. It's not true in maybe every hospital or every unit, but my experience is, and I think you and I've sort of might touch on this a little bit later, which is, is it bad people or is it bad systems,
Yeah.
right? That cause errors, right? And I think bad people is a pretty small minority of the harm that occurs in healthcare. It's generally bad systems, right? We haven't designed systems in ways that let healthcare workers deliver the best care all the time in every situation.
I
I will also
totally,
say one more thing on the
yeah,
topic of in my conversations with patients and families as well, and even just my own personal network. I mean, when I talk about the work I do, almost everyone has a story
mhm.
of a loved one who's been in a hospital, who's developed an infection, who developed a pressure ulcer, who had a medication error, who had some sort of preventable harm. Right. So it's not that these stories are not out there or they aren't happening. I think everyone can sort of resonate with this being a problem, but I think you're so right. We just haven't somehow been able to harness that collective experience into a movement that really demands and requires action.
Well, we're going to die trying. What can I say?
Uh,
Uh, But, I would add one thing just super quickly to what you said about it mostly being good people who work in the systems and bad systems. I agree with that. And then I think that there's one thing in between there, which is good people who entered the profession for the right reasons, but the system crushed them. The system, as they would describe, they were the victim of repeated moral injuries, and they became a bad doctor or they became a bad nurse because the system just beat them down.
Right, which once again I think goes back to the question of could we do a better job designing systems so that people can come and do what they want to do and feel driven to do, which is deliver high quality, safe care.
Yeah.
And obviously, you've been part of cases where there are really bad actors, right? So I'm not in any way
True.
trying to say that isn't out there, but I
Yes.
think that is the very small minority
Yes.
compared to most of the harm that occurs in our healthcare system and
We do come
people wanting to do the right thing. Yeah.
Yes, we do come across your basic garden variety sociopath from time to time.
Hmm. Yeah,
And
for
they're
sure.
out there. I'm sure they're in every profession. But,
Exactly.
well, let's just start with this question. When we start talking about human error, one in my world, the attorneys defending the doctors and the hospitals and whatnot, they would say, we're talking about human beings. Human beings are human. Humans will make errors. There is so much variability in medicine that healthcare providers should be given a wide degree of latitude to make mistakes and it still not rise to the level of a malpractice suit. And frankly, they are given wide latitude. But my question for you is, can human error be eliminated with proper systems engineering?
So it's interesting. I think I would have answered this question differently a couple of days ago than today. And I've been reflecting on this because I have a loved one who's a nurse in a hospital, who unfortunately 2 days ago did actually have a medication error. Fortunately, it did not harm the patient, so that's a very good outcome. But it was a situation where a partial dose was supposed to be given and a full dose was given, so there was an incremental dose, that was um, given to the patient that wasn't necessarily expected or anticipated. Um, and this is someone who I deeply, deeply wants to do the right thing for their patients, who really, really wants to care for them. So, and what happened was they just neglected to scan the med before giving it to them. The patient's husband was in the room and was chit chatting away and distracting the nurse, and the nurse overlooked that important safety step. So as I've been reflecting on this, it was a little bit like, well, is there the way to engineer a system where that wouldn't happen? Like where distraction, right? Because we're humans. You're supposed to follow certain processes, but if someone's talking to you, if someone's interrupting you, you could see how you may not necessarily do that exact safety step every time. And so what I thought about today is I was like, you know what? I mean, maybe there would be a way to, with software and engineering, to not allow a medication to be given until it's been scanned, right? Like maybe you could somehow create a cap on the medication. This was particularly a vial where you couldn't release it unless the medication had been scanned. So I think I'm sort of leaning maybe towards maybe there are opportunities to do it. I think the question is, do we have the technologies to do it? What are the costs of doing that? But ultimately, I think it could be done. I mean, the example I like to think of too is with gasoline. I think they've pretty much at this point designed gas pumps where the diesel pump is shaped differently than the regular gasoline pump. And as I understand it, you couldn't necessarily put one in your car if it wasn't the correct one, right? So we've found ways of designing things so that mistakes can't be made. And so, yeah, I think it can be done. I think it's just a matter of, do we have the investment in terms of finances and sort of energy to take on all those challenges.
Right.
Anyway, that was just sort of where I'm landing today on that question.
Well, fair enough. But let's take this to another example. There's so much study about wrong side surgery, operating on the wrong body part, whatnot. The Joint Commission came out years ago with a toolbox or a toolkit for clinicians. Here's exactly what to do. Follow these steps, and thou shalt not ever accidentally operate on the wrong body part. And yet, wrong site surgeries occur all the time in the United States. So from a systems engineering standpoint, how do you explain that?
Well, I think there's two things. One is you're still dealing with humans, right? So even though you've given humans a 10-point checklist of this is what you're supposed to do, we're still relying on that the human's going to do that. They're going to follow it. They aren't going to have any confusion. They aren't going to have any distractions, and that they do those 10 things exactly as prescribed. So, and maybe to sort of argue in favor of the idea that humans are humans, and with humans, you're going to have human error. I think there's also, as I've been learning in my own journey, because I've sort of thought the same thing, Kay, too. Like, well, why would this happen? And a few years ago, I was talking with some ophthalmology colleagues, and they actually did have a wrong site surgery here at Hopkins. And it was an interesting case of a patient with really dark skin pigmentation. And so the traditional method of, using a marker to mark the surgical site actually didn't work with this patient.
Mm.
because their skin pigment was so dark that you couldn't see what had been marked with a marker. And that had never dawned on me as a potential like way that this system solution could actually fail, right? And how you could wind up with a wrong site surgery. And so they were brainstorming what could we do differently in those situations with darker pigmented skin patients to make sure that we didn't have another um, example of a wrong site surgery. So I mean, I think it's both humans are humans, and I think it's that sometimes maybe our processes continue to need to be revised and updated and rethought through and adapted right to the circumstances. So I think it's a combination of both.
Well, to the point we were talking about earlier, it's not a lack of how, it's sort of a lack of try with some institutions. Um, what I see is a system's only as good as the intent to enforce it is. So, by way of example, I'm just thinking of cases right now where, um, there's supposed to be a mandatory timeout before
Hmm.
surgical procedures where they go over, what's the patient, what's the procedure, what's the right body part. And that's one of the primary ways that they prevent things like that from occurring. But if you've got a hospital, for example, who's pressuring the OR to increase their turnover rates, listen, we need to be moving because some pencil pusher has figured out if we could operate on 2 additional patients in OR number 7, push that through, get a higher push-through rate, that would result in X number of billions for the or whatever for the hospital. So, there's pressure to not follow the safety systems. Um, Furthermore, there's no like, when a plane crashes, they get the black box, and the FAA descends upon the scene. Um, there is no such thing in healthcare. Um, Yet we could have a whole separate conversation about black
I was going to
boxes.
say,
Yeah, I wanna have you back a dozen times. There's so much we could talk about. But I also think there's other perverse economic disincentives, which is, and I'm not saying that anybody wants to hurt a patient, but because of decades of politicians who have gotten in bed with powerful lobbies, we have laws that are so onerous on patients that most patients cannot find a lawyer to take their case. The few who can find a lawyer to take their case are completely hamstrung by caps, which we have in every state. So there's no government agency that's going to come raining down reliably and penalize a hospital for not following the systems. And the lawsuit, if it does happen, is not going to give enough of a sting in most cases, save and except the absolute most catastrophic cases with profound economic consequences. So,
so a couple of things. Yes, I would agree. We have a healthcare system that's probably not optimally designed, right? From the financial structures to the care delivery structure. So I can't argue with you on that point, nor would I argue with anyone on that. There has been some push and movement, not from myself, but I'm aware of their efforts towards like a national patient safety board, right? So in aviation, there's the national, I'm drawing a blank on the name. But
aeronautics, yeah,
yeah. But there's sort of
yeah.
an equivalent, right? When there's an airplane crash, they're the ones that come in and investigate, right? And so
NTSB?
NTSB,
Yeah.
thank you, National Transportation Safety Board, thank you. So there's been efforts through the last decade to create sort of a national patient safety board
Mhm.
that could act in a similar capacity, right? To both, I think, highlight where harms are happening and hold institutions accountable. when harms are happening. Um, so that was just one example of where I think there are efforts to try to move in that direction. But I agree, we're fighting an uphill battle of some very, very invested interest groups and groups that want to sort of maintain the status quo for a variety of reasons.
Well, I think we could do many deep dives about particular types of, never events that they would call them, sentinel events, never events, catching the patient on fire in the operating room. We know how to prevent that, yet that happens. Retain foreign objects, sponges, forceps, things of that nature, things that most people would say, what? That's actually happening? But I think something else that I have finally, as long as I've been at this as a medical malpractice lawyer, things can be very, very complicated in medical malpractice litigation. But what I have found as of late is that the complex is almost always simple, in the sense that I will dig and dig and dig and dig, and oftentimes take a lot of depositions and review thousands of pages of documents until I can figure out, you know what? The root cause of all of this happened over here because Dr. A handed patient off to Dr. B, and there was a communication breakdown between the two of them, or whatever it might be. That complex problems sometimes have very simple causes. What do you think of that?
I think that has truth to it. I think communication is obviously one of the great causes and risks for patient safety events. So I would agree with that. What we often talk about in this space too is something called the Swiss cheese model, which is where, you know, there may be a little bit of a safety gap in one process and another safety gap in another process and another safety gap in another process. And it just happens that those three all lined up, right? So in most days, one of those threes would have caught it, right? But there may have been a particular situation or circumstance in which all of those line up and you're able to sort of go through the Swiss cheese. And that's how the error has happened. So I think some of it is, yes, communication, but I think it's also how do you have different layers of sort of safeguards put in place to try to catch where those errors and gaps have happened.
Well, there's sort of an elephant in the room in this conversation, and that is artificial intelligence. And, it's not in the future, it's now. It's on fire, it's everywhere, in healthcare as everywhere else. So I'm interested, two things. Number one, would you please come back and we could devote at least 2 episodes to just talking about AI in patient safety? Number two, so interested in your thoughts, and maybe the answer is too early to tell. There could be an opportunity with AI to transform healthcare, to make it so much safer for patients and so much better, so that we're all living longer, healthier lives. Or it could be the end of us. It could be a terrible disaster for healthcare. So do you have preliminary thoughts about that?
So I have some preliminary thoughts, which I think sort of match yours. What I was going to add to what you said was, or it could be both, Kay, right? That it brings us the best healthcare ever, and it also winds up being a disaster. In conversations that I've had with colleagues, one in particular framed it as sort of offense and defense. So not to lean too much into sports as an analogy, but offense in the sense of, to your point, what can artificial intelligence do for us to improve patient safety, right? How do we actually make a better, safer healthcare system? And is artificial intelligence part of that? On the defense side, it's, oh my gosh, how do we make sure that artificial intelligence doesn't create additional patient safety risks, right? So it could really be the best thing that's ever happened. It could be the worst thing that's ever happened. It's probably going to land somewhere in the middle and be a mixture of both.
Yeah.
So I think we have to sort of think about it in those two camps. It's like, what can it do for us? And what do we need to make sure it doesn't do for us?
Yes.
Those are my preliminary thoughts. I don't claim to be the all-knowing expert on artificial intelligence. I did get the opportunity to listen in on a webinar the other day that where some researchers had evaluated ChatGPT health, specifically around some, questions that a patient may have if they felt like they were facing some sort of emergency, and found that the ChatGPT health over triaged in certain situations where probably the patient didn't really need to go to the emergency department, but it recommended that they do. And there were also problems with under triaging where the patient had serious clinical problems. And it basically said, well, you can wait 48 hours to make a doctor's appointment. And so I think in the scheme of, obviously models need to be improved, right? So we're in the early days of these technologies. I have significant concerns with trust. How do we trust the technology to make sure it's actually doing what it should be doing and what it needs to be doing? And I'm not quite sure what the answer to that is yet, and how we're going to establish that trust sort of level with these technologies.
Well, totally agree. I see tremendous opportunities, but I also know that um, the ones that won't have any say so over AI is the patient. I think the payor is going to have the most influence over whether and how AI is used in healthcare. And by payor, I mean the health insurance company or whatnot. And if they can figure out that a robot can run down the hall and interact with the hospitalized patient, or an ICU can be virtually staffed and they don't really need to pay doctors to be there, or if we can get robots to where they're operating on people instead of having to pay surgeons $1 million a year or whatnot, that's going to be thrust upon us because those are for-profit corporations. And, their leaders themselves are making hundreds of millions of dollars in salaries and bonuses every year that, we're a capitalistic society, and they will see or already have seen opportunities to make exponentially greater profits. And their job is not patient safety. Let's be honest, the health insurance companies, that's not their core business principle. Their core business principle is to collect more in premiums than they pay out for healthcare. So that may sound like sort of a jaded view, but I come by it naturally from being in the profession for 40 years.
No, and it's interesting. I think you are right about payers playing an important role in terms of adoption of technology. About a month or so ago, attended a day-long session that looked at a technology using artificial intelligence that does scans of patients' eyes, and it sort of assesses the likelihood of them having diabetic retinopathy. And if they're, if it's they, had millions of scans that they had done and had established who actually had the condition and who didn't. And so it's sort of building upon those models of having a million scans to go off of. And, the idea is that this technology could actually be used in like a primary care physician's office. And so instead of sending the patient off to an optometrist or an ophthalmologist for an eye appointment, you could do the scan at their PCP visit and sort of make an assessment whether or not they need to go see a specialist of some sort. So obviously they needed to get FDA approval for the use of that technology because it is considered a medical device. But what was interesting, it was an additional, I think, 3 years of advocacy with CMS, Medicare and Medicaid, to actually pay for that exam, right? So the payer was sort of holding the key or the card to whether or not that technology actually got deployed in sort of a mass way. So I would agree with you. I think payers do hold a lot of power and control. I do a lot of work with employers, right? So in the United States, we operate a primarily employment-based insurance system.
Mhm.
So it's actually employers that are paying for a lot of the healthcare in the United States who are actually contracting with the health plans to be the middleman to carry out all the health benefits, right? So it would be interesting to me, what role can the employers play, excuse me,
Yes.
to really sort of put pressure on the health plans and say, no, patient safety is important. These are our employees, these are our employees' families that are being harmed, and we need to do something differently, and we are going to hold you accountable for making sure that care is safe.
100%. And this is another episode that I want to have you back for, and that is to talk more about your work with the Leapfrog Group. And I
Mhm.
believe that's what you're referring to.
Correct. Yes. Yep.
Fascinating. Fascinating. It's another leverage point. Um,
It is, right? And it's one that I think, we talk a lot about. Employers probably underestimate the leverage that they have in our
Mhm.
healthcare system. Now, some of it is because, they're building cars, they're building widgets, healthcare isn't their primary business, but they are actually paying for a lot of the healthcare in the United States and actually have an important voice, I think, that they sort of underutilize in terms of driving better quality and safety of healthcare.
Well, absolutely. And I you've been so gracious to agree to stay for another episode because I want to really get down to it, um, and talk about some of the studies that you shared with me about particular types of misdiagnoses and things of that nature. And we can kind of get inside your brain about how things like this are studied. I really want to thank Dr. Matt Austin for agreeing to come on the podcast and be a guest. I think it's absolutely fascinating to consider that even though humans are humans and humans are prone to error, that science exists to engineer out the root causes of humans making errors. In this way, preventable medical errors can be reduced and fewer patients, I should say, will be harmed, which is what I'm all about. So thank you, Dr. Austin, for coming on as a guest this week. Stay tuned in future episodes where Dr. Matt Austin will come back and we'll do an even deeper dive on human factors engineering and some of the specific work that he and others at Johns Hopkins are doing in order to prevent medical errors from harming patients. Next week, Ann Roberts will be back. I'm super excited. Ann Roberts is a C-suite executive insider in the healthcare industry for an undisclosed major prestigious hospital in the Northeast. And she's going to come back and share her experience with us from the standpoint of the hospital. What's the hospital's role in preventing medical errors and making sure that doctors are safe, trying to make sure that patients are safe? So, really looking forward to having Ann Roberts back next week. Please stay tuned and come back next week.